Izadidehkordi. She has a PharmD degree and is a licensed community pharmacist and has been a visiting scholar at UConn since January and has already gotten involved in a lot of cross-disciplinary collaborations here. Her research expertise is in the area of pharmaceutical outcomes research, including pharmacoeconomics, cost-effectiveness analysis, and economic evaluations of pharmaceutical products. She's also interested in health economics and outcomes research, pharmaceutical healthcare modeling research, and applying real-world data to clinical trials for model development. The lecture she's going to be providing today focuses on introducing some common methodologies for conducting cost-effectiveness analyses on healthcare interventions, with a special focus on the cost-effectiveness analyses she's doing on a biobehavioral primary HIV prevention intervention among high-risk people who use drugs. This is a trial that we recently completed, NIH-funded trial in New Haven. So we'll have her present for about 45 minutes, and then we'll save some time at the end for questions and discussion. You can either chime in with verbal questions and discussion, or you can put a question in the chat box if you prefer. So I will hand it over to Shadi.
Hello, everyone. I'm so excited that I'm giving a lecture today on cost effectiveness of healthcare interventions with a special focus on a dynamic HIV model that we recently developed. So I'm going to talk about our session agenda. First, I'm going to talk about how I was exposed to the area of decision analysis in healthcare, and then jump into what is cost effectiveness analysis and what are the methods for conducting a CEA. Finally, I will talk about the research project that we recently had, a dynamic transmission model for an NIH-funded HIV prevention intervention. A little bit of background about myself. I first became exposed with the concept of cost effectiveness when I attended a public health HIV awareness campaign as an undergrad. And I realized many preventive interventions are prioritized over treatment because of their power in cost saving. Then, as a PharmD candidate, I became exposed how cost effectiveness is used for designing reimbursement plans, essential medicines list, and preferred drug list. I had the amazing opportunity to attend World Health Assembly at WHO headquarters when I realized we have a limited global healthcare budget and how WHO decides about cost effectiveness of interventions on a global scale. I became familiar with the research area of health outcomes and economics research, which doing a cost effectiveness is a subset of that research area. And now I'm currently doing cost effectiveness modeling and how to put cost effectiveness on epidemiological level. When it comes to conducting a CEA, there are two things that we need to look at: the effects and the costs. And things are easy when there is a balance between the effects and the costs. But there are sometimes challenging situations where we need to put more cost but get a less effect out of the intervention. We always have to ask this question: is the effect worth the cost or not? In order to answer that question, we need to have unified metrics both for the costs and for the effects of each intervention. For costs, it's easy because we have that dollar sign, but when it comes to health outcomes, we might have a medication that has several different strategies, several different health outcomes. For instance, it can prevent hospitalization and relapse at the same time, but also improving mortality. If we want to unify all those health outcomes into one metric, we can use what's called QALY, which is quality adjusted life years. It's a metric, its formula is length of time in each health state multiplied by the utility of health state. And the utility of health state is a universal scale between 0 and 1 is for perfect health, and 0 is for people who are going into diseased compartment. There are other health outcomes that we can use in cost effectiveness, for instance, DALY or disability adjusted life years gained, which is an overall survival health outcome, is used usually in oncology. We also have hospitalization periods, which is an example of healthcare utilization, health outcome measurements. When it comes to infectious disease, we have this concept of infections averted, which is the result of effective interventions on transmission and incidence. And finally, if we want to look at health outcomes on a societal level, we can account for productivity loss. When it comes to costs, rather than inserting direct costs such as medication costs, we can also insert administration costs, for instance, for chemotherapeutic medications, because patients have to go to a healthcare facility to receive injections sometimes. Another cost that we can take into account is monitoring and diagnostic test costs. An example of an HIV intervention, we want to continuously follow up patients so that we know what's their HIV status, and we need to consider that cost in our model. But we also need to capture hospitalization costs in chronic illnesses such as sickle cell, where there are episodes of hospitalizations, and it's very important in that area. Also, we have adverse events costs. I brought the example of opioid use disorder because if we look at it in a way that overprescription of opioid medications cause this crisis right now, because a strong side effect of opioid medications where they're highly addictive nature, and that's what we have this crisis right now. Also, we can look at societal costs, which is called also opportunity costs from perspective of patients and caregivers. And by that, I mean, when a caregiver comes to you to a healthcare facility when you want to receive your medication, he's losing that day at job. So that cost can also be taken into account. CEAs also have limitations. The first limitation is that not always we can compare different disease areas with each other. For instance, a flu vaccine cannot be compared with a hypertension drug. There are also other challenges such as equity challenge and equality challenge. And by equity challenge, when you put a monetary value to the life years of people, it might raise ethical objections. For instance, when it comes to vulnerable populations, people with chronic conditions, these are not starting or living their life with the same health utility as other general public, and they might not be subject to receiving certain interventions because it's not cost effective for them. The equality challenge is that sometimes the results of cost effectiveness is not generalizable to other segments of the population, and that's when we see some parts of the population have access limitation and the insurance does not cover the cost of interventions for them. So we talked a little bit about cost effectiveness, but now we want to see what are the steps of conducting a CEA. The first step is outcome selection, and the more comprehensive the outcome we select, the better. We want to make sure that we both capture the quality and the quantity of health states that the patients are in, but also to capture all the events that are happening over the course of the treatment, for instance, any side effects or complications that they might have. Then we want to see what costs we want to insert into our model and what is the time horizon of the model. When it comes to an area like HIV, for instance, we want to make sure that we capture that step when HIV is progressed to AIDS, which on average takes about 10 years if the patients are not put on antiretroviral therapies. And for that reason, we want to make sure we have our model running for at least 10 years. We also need to select the perspective of our CEA do we want to do it from perspective of patients, caregivers, or the healthcare system, which is usually what cost effectiveness are done. We need to decide which threshold we want to use for cost effectiveness, and I will talk about it in a couple of slides. And finally, once we gathered all those informations about the outcomes, costs, and everything, we want to put it into a model that best captures what's happening in reality. For outcome extraction sources, the most reliable source we can use is meta-analysis. It is advised by the guideline to do a meta-analysis if we do not currently have one in a certain disease area. And then we can use also randomized clinical trials as the second most reliable source, followed by real-world evidence, examples of which could be electronic health records, claims data, and data for Medicare and Medicaid services. Also, we can use experimental and quasi-experimental studies, followed by epidemiological cohorts, which is usually used when we want to model CEA on an epidemiological level. I talked about cost-effectiveness threshold, and the cost-effectiveness threshold is something that we want to compare our interventions based on. If the results of our CEA exceeds that threshold, that means that the intervention might not be cost-effective. And the first threshold that was introduced for conducting a CEA was introduced by WHO in 2001. They decided to use gross domestic product per capita as a threshold for cost effectiveness. It is obvious that that threshold has a direct relationship with the economic prosperity of the countries. For instance, United States with GDP per capita of 85,000 can have access to a wide variety of interventions and high-tech medications, while other countries are just not having access because the cost effectiveness threshold is lower in them. In order to solve this problem, WHO published a bulletin in 2016 advocating for another threshold called willingness to pay per collie. And that threshold is basically asking patients how much they are willing to pay for gaining 1 year of perfect life. This threshold is a little bit better than the GDP per capita because it's a patient preference-based threshold, but it still varies between different countries. For US, currently, the threshold that we have is between 50,000 and 100,000. The next step is we have that threshold, but we want to see how we report our cost effectiveness results so that we can compare it with the threshold. There are three main ways to report cost effectiveness results. The first one is ICER, or incremental cost effectiveness ratio, which is subtracting the cost of a standard of care from the cost of intervention and then dividing it by the differences in the collies between a standard of care with intervention. If that ICER turns out to be higher than willingness to pay per collie threshold that I explained in the previous slide, then the intervention is not cost effective. But there are other ways that we can report cost effectiveness results in a linear way rather than a ratio, and these are incremental net monetary benefit and incremental net health benefit. The INMB reports the results in dollars, while the incremental net health benefit reports it in terms of collies. And these are very easy to work with because if the number is negative, that means the intervention is not cost effective, and if the result is positive, it means that it's cost effective. This is called cost effectiveness plane, which is almost seen in all the cost effectiveness studies that we see in literature. There is this willingness to pay line that is dividing the green area from the red area, which explains which interventions are found to be cost effective. We have these areas on the right bottom of the slide, which is the dominant area, which is where we have a highest level of effectiveness, but we are spending lowest cost. which is always the case of a cost-effective intervention. On the top left of the slide, we have dominated area, which is always not cost-effective because we are spending a lot of money, but we are not getting that much an effect. So this is the exciting part when we want to select a model based on all the data that we gathered from the previous steps of conducting a cost effectiveness. I try to categorize the models that are used in cost effectiveness based on the level of the complexity they have. So we start with decision trees and then we move to Markov models, which they focus on the health states the patients are in and the transition between the health states. Then we talk about dynamic models, which try to compensate for the shortages of limitations of Markov models. And finally, we have microsimulation and agent-based models that we are not going to discuss in this lecture, but it's the equivalent of precision medicine, I would say, because they try to capture individual level data on modeling. To start with a decision tree, if you look at the right side of the slide, you can see the most simple representation of a decision tree. So every decision tree starts with a decision node. And then when we make a decision for a patient or the population, for instance, to start them on a medication, then there are a series of events that they are happening as a result of that decision, which they are represented by way of chance nodes. And we have series of chance nodes that are happening with certain probabilities, as you can see as P1 and P2, up until the patients are moving toward the terminal node. And this terminal node can be either when patients are cured because we have a treatment for a certain condition, but if there is not a 100% treat, like in the case of HIV, unfortunately, the patients might go to the deceased compartment, which is a terminal node. With decision trees, we are able to capture outcomes not only on patient level, but also on population level. And then the most important thing is for us to be able to calculate those probabilities using methods such as folding back method or matrix multiplication method, so that we can finally compare those branches in the tree of two different decisions that we are making to see which one is found to be cost effective. This is a schematic decision tree in HIV case, which explains a little bit more about a decision tree. For instance, if we have a person who is acquiring HIV and he just goes to a clinic, there is a high chance that they start him on antiretroviral therapy, but also there is a chance that also the person does not want to start antiretrovirals. And we know these probabilities add up to 1 because we only have 2 options here. And then as a result of a decision, which is starting on ART, the patients might start to become virally suppressed, which means the CD4 counts are going to be lower than 200 cells per cubic millimeters. And that's why ART is so effective. But there is a 10% chance that even though they are taking ART, they are not adherent to the medication, or for some other reasons, they are not virally suppressed. And these events, as you can see, they are represented as chance nodes. So the next step would be a person who is virally suppressed is going to be progressed into AIDS compartment, which is usually not the case. And there is a very slight chance that the patients, even they are taking ART, they go into AIDS compartment, but there is still a slight chance, which means in 99% of the time, the patients don't even go to that AIDS compartment, and they don't have to deal with all those complications that people who are having AIDS are having. At the end of the decision tree, the patients, unfortunately, all go through the deceased compartment, because we know sooner or later the patients are not gonna survive, because HIV is not a curable disease yet. So I think you have a good grasp of how decision trees work. If we want to conduct a CEA, in this case, we are comparing the branch that people are using ART with the branch that the people are not using ART. Then let's move to Markov models. Markov models are also called state transition models because they divide the population into mutually exclusive states, and there are transition probabilities between those states. And when it comes to Markov models, we do it on population. So the average population in a given state is what we capture. We have this rule of memorylessness or Markovian assumption, which helps us to calculate the probabilities, just like we did in decision trees, which says that transition probabilities only depend on the current health state that the patients are in, and it doesn't care about the past. It's the preferred method for chronic illnesses because we usually have different health states in those illnesses, and also time-varying states such as sickle cell disease when patients go through hospitalization periods and each health state is different with the other, and also in case of recurring states such as MS. This is an schematic Markov model for HIV that helps to better understand how Markov models work. So the population is divided into 4 compartments: susceptible, HIV, AIDS, and disease. And we have on the right side of the slide this transition probability matrix that captures all the states that the patients are moving from. And the rule is here that for instance, for a susceptible person, there are 3 options that that susceptible person has to get infected with HIV, or stay susceptible, not getting HIV, or go directly to the disease compartment, which is not related to HIV at all. And the probabilities of that state should add up to 1. And that's how the Markov model works. The results of a Markov model is usually reported by way of a cohort trace in which we have the whole population and the proportion of the cohort on the vertical axis, and we have the years that we want to model the intervention on the horizontal axis. And as you can see, the number of susceptible at first is consisting all of the population because the infection has not started yet. But as time passes by, the number of susceptible people just declines because more and more people are getting HIV. So that's how cohort trace shows how the proportion of cohort changes over time in a Markov model. An example of how we can do a CEA on Markov model is here when they were trying to capture how pre-exposure prophylaxis, a medication that prevents HIV transmission, can change this cohort trace that I previously explained. So in the right side of the slide, you see that cohort trace, which as a result of improving PrEP coverage in the population, we see the number of people living with HIV is decreasing compared to when we don't have any PrEP coverage. And that's exactly where the arrow between susceptible and HIV was infected. It's just affecting the transition probability of susceptible population that they want to get HIV infections. But there's a question here, and is the fact that in Markov models, we have fixed transition probabilities. So it's always people are getting HIV in a constant rate. But we know in reality that's not the case because as people are getting HIV in the population, the people are getting HIV in a higher probability because they are basically more exposed to the population that they are having HIV. So it is a dynamic process rather than being a fixed probability. It's just like prevalence of HIV changes all over time rather than being fixed. In order for us to be able to solve that problem of fixed transition probabilities, we use what's called transmission dynamic models. And these models try to capture the risk of infection, incidence, and prevalence as dynamic parameters rather than fixed transition probabilities. They are also able to capture heterogeneity in the population. For instance, we are able to divide the population into subgroups based on their age, their behavior pattern, their geographic place of living, because these subgroups have different risks for infection, and there are different forces of infections and contact structures. For instance, when it comes to HIV, we know people who inject drugs are high-risk population for HIV because they have sharing injection behaviors. So the contact structure is different from other subgroups in the population. And we can capture that contact structure through a contact matrix, which is denoted as CIJ here in the formula with a transmission dynamic model. Lastly, using transmission dynamic models, we can forecast the long-term effects of our intervention, especially when the intervention is affecting disease dynamics on a population level. For instance, we want to improve pre-exposure prophylaxis coverage, or ART, on a population level, and to see how much this intervention impacts the incidence and prevalence of HIV epidemic. It is also the case with vaccination. So that I talked about the benefits of transmission dynamic diseases, I want to talk about our recent project, which was developing a dynamic cost effectiveness model for the intervention called CHRP-BB. CHRP-BB is a biobehavioral community-friendly health recovery program, which is NIH-funded and focuses on reducing HIV transmission risk associated with both sex and drug injection through a combination of harm reduction strategies and pre-exposure prophylaxis adherence improvement. This intervention is designed for people with opioid use disorder who are receiving medication for opioid use disorder, or MOUD, and they are considered high risk for HIV transmission. The data collection happened between 2018 and 2023. This intervention is part of the big Ending HIV Epidemic initiative, which was introduced a couple of years ago with the goals of reducing new HIV infections by 75% by the end of 2025, and then by 90% by the end of 2030. One of the goals of the EHE initiative was to improve PrEP coverage amongst high-risk population, which aligned with our study population. These figures show what's happening in reality based on the CDC statistics. We can see the HIV incidence between 2019 and 2022 has decreased, but that decrease is not even close to the goals of EHE epidemic initiative. It's just 35,000 in 2019 compared with 32,000 in 2022. And also HIV number of diagnoses are increasing. In terms of HIV prevalence, we also see that there is a pattern that prevalence of HIV is increasing. I did not include the 2022 data because it was like in the midst of pandemic, and just the whole dynamic of HIV epidemic was influenced by the pandemic. When it came to PrEP coverage, we see that the number of persons who are prescribed with PrEP has increased between 2019 and 2022, reaching around 420,000 number. which is almost 30% of the population who are eligible to receive PrEP. But there is an interesting thing here, and is if we compare that data with estimated HIV infections among people who inject drugs, we see a decrease in 2022, which could be justified by the PrEP coverage that was increased in that year. And we know that people who inject drugs are 22 times more likely to acquire HIV than the general population. So it's very important to focus in this population to combat the HIV epidemic. So from now on, I would like to talk a little bit of what are the steps of developing a dynamic transmission model. The first step, as you remember from previous slides, is to come up with model outcomes and model costs. And for outcomes, we used HIV transmission rate reduction and the consequences of that transmission reduction in the number of HIV infections being averted. We also reported COLIs. And for model costs, we used intervention costs such as logistics and counselor salaries. We used PrEP costs, which we see there is a wide variety of numbers because there was a generic version of PrEP introduced into the market. We also used ART costs, which are extremely high. It's about 36,000 to 48,000 USDs per year. And something that I would like to especially focus is the cost of complications and comorbidities in people aging with HIV. And by that, I mean, there was this study in 2017 that was trying to capture what are the costs of complications in people aging with HIV. When people reach 60 years old, the cost of complications even exceeds the costs of ART, which is by itself extremely high, and that's something that should be captured in all HIV modeling practices. For model parameters, we had 4 sets of parameters. First, we had intervention parameters, including probability of sharing injections amongst PWIDs, probability of inconsistent condom use, which was part of the harm reduction strategy of the CHRP-BB. We also had probability of adherence to PrEP and probability of cleaning syringes prior to sharing, because part of the practice was to teach PWIDs how to clean syringes properly. We had clinical parameters that we needed to extract from literature, such as ART effectiveness, PrEP effectiveness, syringe cleaning effectiveness, and HIV transmission rate per sexual act or injection. For epidemiologic parameters, we used epidemiologic data sets, such as like incidence, prevalence, and mortality, also for ART, PrEP, and MOUD coverage. For the cost parameters, we used insurance and pharmacy claims, also PrEP and ART cost analysis reports, and we asked the project manager of the intervention to come up with financial sheets for the costs of interventions. So step 3 for developing a dynamic transmission model is to come up with a transmission term, and that's an exclusive step for these types of models. And by transmission term definition, I mean we need to develop a mathematical notation using all those model parameters that I discussed in the previous slide for HIV transmission per capita, both for sex and injection-based pathways of HIV transmission. And by that, I mean that we need to capture all the possible scenarios when an HIV-positive person becomes in contact with an HIV negative person. When it comes to HIV injection, for instance, we assume that an HIV positive person is injecting drugs and is sharing injection. What's the probability that that HIV positive person is on ART? And if they are on ART, what's the probability that they are virally suppressed? What's the probability that if they share injection with an HIV negative person, the HIV is going to be transmitted through that injection? And what if the other person is on PrEP and is immune to receiving HIV? For sexual transmission, this mathematical notation includes the sexual acts that person has on for instance, on a monthly or on an annual basis. How many partners does that HIV positive person have? What's the probability of condom effectiveness if they are using condoms properly? So all these parameters should be put into a model so that we can get an idea of how HIV transmission is happening. The next step is to calibrate that transmission terms that we have developed, and that's when we want to adjust those uncertain parameters until the model reproduces observed epidemiological data. Given all the parameters of the model, are we seeing the same HIV prevalence and incidence and mortality that is happening right now? This calibration step also helps us to come up with plausible parameter distributions, which we can later use for uncertainty or sensitivity analysis. And it prevents over or underestimation of intervention effect, because we know in base case scenario, we are capturing what is really happening. And now we are able to put the intervention effect to see what's happening if we intervene. So at the end of the calibration state, we have this beta, which is transmission rate per capita, which is calibrated to the observed data. And we have beta for the intervention when we put the model parameters into the model to get the HIV transmission in the intervention scenario. Then we go to the next step, which is ordinary differential equations. And the ordinary differential equations, or ODEs in short, are the systems that they can capture what's happening dynamically over the time horizon of the model. If you remember Markov models, we had fixed probabilities, so the population was moving at a fixed rate. But with ODEs, we are able to use different compartments to move dynamically so that we capture the flow of the population as the number of infections increases. If you look at the right side of the slide, you can see the most simple ODE system, which is used in epidemiologic modeling, called SIR model, which divides the population into 3 compartments of susceptible, infected, and recovered or removed in our case. We see that the patients who are susceptible, they are getting infected with a certain beta, which is the transmission that we have, and then they move to infected compartment, but at the same time, some of the infected compartment go to removed compartment, and we are able to compare those scenarios that we have for the baseline with the intervention in order to estimate the compartment sizes. And by compartment sizes, I mean how many people would be susceptible by the end of year 2, for instance, how many people would be infected and how many people would be removed. Once we have those compartment sizes, we can calculate the outcomes that we want to see as a result of the intervention, which are incidence, prevalence, and infections averted. For instance, for infections averted, we should calculate the difference between number of infected people in baseline scenario versus the number of infected people as a result of our intervention. We can also calculate how prevalence is different and how incidence is different, because we have all the compartment sizes. And we use mathematical methods for solving the system of ODEs to come up with these compartment sizes. The last thing that we do is we put the costs and COLIs into those scenarios, like the baseline scenario and the intervention scenario, and we calculate ICER, and that's the end. But there is a very big question here, and that's what if? What if, like, the model that we developed does not work with the same parameters that we had? What if we could change some parameter values to see what happens? This is when sensitivity analysis comes into effect, and that's when we can change the input of the model parameters to see how they impact the output. We can capture the uncertainty of model parameters also to see how they affect the outcome. And by that mean, this is an example of a needle sharing probability distribution. We need that, like, on average, the population, around 30 to 40% of the population are sharing needles when they inject. But there are other values that are possible, and that's what I mean by uncertainty of the model parameters. We are able to capture those least prevalent scenarios as well. And then we can come up with an optimal strategy across a range of input parameters that we can decide which is the most cost-effective intervention. Sensitivity analysis, there are two certain types that we can use to calculate the scenarios. The first is deterministic, and the second is probabilistic. Deterministic, by that I mean is that we change the input parameters for one input, which is called one-way sensitivity analysis, or a couple of inputs, which is multi-way sensitivity analysis. And we report the results in a way that is called a tornado plot. And the tornado plot shows how each input is most sensitive to the results of our model. For instance, in this case, we see ART lifetime cost is the most sensitive input. We know if we change that variable a little bit, the results of the outcome changes dramatically. And for probabilistic sensitivity analysis, that's even more interesting because we are able to see how uncertainty in a model's input affects the output. Do you remember the previous slide here that we had uncertainty over a model parameter? If we put all those uncertainties and simulate the model repeatedly, applying random inputs drawn from probability distributions, of all the models in the parameter, which is also called Monte Carlo simulation, we are able to see the probability of cost effectiveness on interventions. Like in this case, for instance, you can see on the line that almost 80% of the time, it's the probability of cost effectiveness of this intervention is 80%. And it gets more interesting because we are able to calculate scenarios. For instance, we know only 25% of eligible cases receive MOUD. But if we can improve the coverage of MOUD so that we can improve the coverage of our intervention on MOUD and then see what happens. Or the PrEP coverage amongst people who inject drugs is currently among 0.1 to 2%. What if we could improve that PrEP coverage to see what happens? What if we could improve the intervention effect that we are doing, how we can optimize the effects of interventions? Then we simulate the scenarios that we have here to get to what's called optimal strategy. As you can see here, in 100% of the cases, the intervention turns out to be cost effective because we use the optimal parameters. I think it took so long, but here is the last slide. Here are some references for CEA modeling. You can take a look later. And these are funding resources that was used for conducting this modeling study, and thank you for your attention. If you have any questions, please let me know.
Great, thanks very much, Shadi. Do you want to take down unshare your slides?
Yeah.
Even though we may have to go back to those depending on if people have questions. So we have time for a few questions if anyone wants to chime in. And yeah, so people can unmute themselves if they want to chime in. That'll be even more effective. All right. Well, I have a question. This is going to be coming from a pretty naive perspective, but I'm wondering if like what determines whether you conduct a sensitivity analysis is that if the model is not not working properly, or like how do you? It sounds like you put the model together, you kind of see how things work, and then if it doesn't turn out the way you were expecting, you start sort of playing around with the analysis a little bit in the sensitivity part, which seems pretty exciting to be able to, figure out what needs to happen to make it cost effective. But I just wonder if you could speak to that a little.
Yes, so for sensitivity analysis, we have a number of parameters that are not certain all the time. For instance, we have an intervention and we know that intervention has an effect, but we are able to improve the intervention effect if we improve that certain parameter. For instance, in the case of the harm reduction that we did, we were trying to capture how the probability of sharing injections changes, how the probability of PrEP adherence changes. And we knew that it was our intervention effect. But what if there was an intervention that could do an optimized way of what we did to improve that probability a little more bit so that we can know it reaches the cost effectiveness threshold. For instance, when we simulate our intervention, we see at 60 or 70% of the times, this is a cost-effective intervention. But if there was an optimized intervention that could level up these parameters, we could get an intervention which is almost always a cost-effective intervention to be done.
So you're able to sort of report on what you have, but then also project what it could be if you tweak it in this way or that way.
Yeah, exactly.
Really?
And then we could consider, for instance, this was an intervention that was done on a center where people receive medication for opioid use disorder, and we are able to predict what if this was a multi-center intervention, that we did an intervention on a certain number of people rather than this number that we just did, to see what happens. And that's the exciting part of the sensitivity analysis.
Yeah, that is really exciting. I mean, another aspect of this would be if you're going after a certain target population and you have encouraging results, but then you say, if we open this up to people who are not even in treatment and we get them into treatment, that turns on the positivity even more. So you can have something promising and then say we have something good, but then if we recruit people who we're not even in contact with yet, that changes things dramatically. So
exactly.
Great.
And then we have like the base case scenario, because we already know based on epidemiological data what's the current percentage of people who are receiving medication for opioid use disorder. Then we can see what's the real scenario and then how we can improve it.
All right, other questions?
I think Trisha is on mute.
Yeah, I think you're on mute, Trisha.
That work?
Yes.
Yeah.
Okay. All right. Excellent. I must have hit my microphone button. So first of all, really great talk, Shadi. I enjoyed it. And I'm exploring a lot of cost effectiveness in the trials that we do in obesity treatment and weight management. And, this conversation that you're having with Mike is really interesting in that, a lot of us are looking at like component effectiveness and cost, of individual intervention components, and like factorial designs. And so it's interesting, and I'm just curious if you can clarify this for me. Is it possible then with these sensitivity analyses to say, like, if you were to reduce like the duration of the intervention by 25%, then you could have a cost effectiveness intervention, because then you would eliminate costs associated with intervention delivery, or, so not thinking about drugs so much, but thinking about like person-to-person, therapist intervention delivery. Is that something that you could look at with the sensitivity analyses, such that, in some ways it would make it a lot easier than going through a big factorial trial to try to determine, which components are effective at which levels? So I'm not sure if I'm being clear, but happy to clarify if helpful.
Yeah, I think I got your point, and I would say, yes, it is possible to capture that through sensitivity analysis, but it's in a different sense, because with factorial designs, you are able to get the intervention effect sooner than later for an intervention. And that's the part that we care about, to be able to get that intervention effect. Once we have that intervention effect, then we can model the cost effectiveness of that intervention up until all the events that are happening as a result of the intervention are taken into account. So it's like, as soon as we have that intervention effect being able to be reported, we can do the sensitivity analysis, but we cannot do the sensitivity analysis before having that intervention effect, because the power of the study should be high enough so that we are able to have an intervention effect to put into the CEA. And the other part is about the modeling. So the time horizon of the CEA is something that is different from the time horizon of the intervention. I think I explained your point in a way that makes sense, but feel free to ask any follow-up questions.
No, it does. It does. And we often look at cost per kilogram of weight loss in terms of cost effectiveness analyses. So certainly once we have the data and do a factorial, and then, we can then perhaps use sensitivity analyses to anticipate, if we titrated down the intervention by X%, then maybe we could have a cost-effective intervention instead of doing more and more experiments to try to identify the sweet spot. So I think I understand what you're saying, if that's correct, and it's really interesting.
Yeah, and the factorial designs are becoming widespread, because that's the part that we can, in a sense, think of how we can get the intervention effects sooner than later, so that we can prevent all the costs that are resulting from extending the intervention. And that obviously can be put into the cost effectiveness, the difference in the costs while we're extending the intervention and not.
Thanks, Shadi.
You're welcome.
Other questions?
Sure.
Right, and if you have any burning questions you want to put in the chat, you're welcome to do that, and I'll pass those along.
Or feel free to use your microphones. It's almost easier.
All right. Shadi, anything you want to add? I mean, you are doing some other fascinating work, thinking about how Bayesian methods might be used. Tricia was mentioning, do we have to go through all these factorial experiments and figure out, get an intervention effect, and then you can do the cost effectiveness, or can you just sort of take a shortcut and not have to do all these things and kind of play around with the data in other ways? And you're starting to go into that direction also.
Yes. So currently, the project that we are working on is a optimized way, looking at how we can optimize the intervention effects using Bayesian statistics and also factorial designs, as Tricia also mentioned, so that we are able to get that intervention effects sooner, and also use the Bayesian techniques in order to report even the intervention effect in a Bayesian way rather than the standard statistics way, because we are able to say there is, for instance, a 90% probability that our intervention is having this certain effect, which helps us to even reach the conclusion that it is sooner at a sooner time rather than later, which really helps in optimizing the whole process of interventions and cost effectiveness. And I would like to mention also this probabilistic sensitivity analysis is also somehow a Bayesian technique, because it concludes it's about probabilistic concept, how what's the probability that the intervention is cost effective rather than being cost effective or not. It just measures what's the probability. So it's a Bayesian thing.
And these techniques come in really handy when, just like everyone else, we're having struggles with recruitment and may not get to the place where we have super powered trial. And these Bayesian techniques could fill in the gaps in important ways. It's no substitute for recruiting, obviously, but it may be a way to salvage a study that otherwise would not be able to do these analyses.
Yes.
All right. Any final comments or questions? All right. So thanks very much, Shadi, for a great presentation, and good luck with your future work. I'm counting on it. So
Thank you very much. I was honored to be
Thanks everyone for coming.
Thanks, Shadi. Great to hear about your work. Take care.
Thank you. Bye.